I am back. Let us continue. Raise your hand if you're able to hear me clearly. All right. So we're moving on to the second chapter in the trauma module, bleeding, chapter 25. Introduction. It is important to be able to recognize bleeding and understand how bleeding affects the body. Bleeding can be external or it can be internal. Bleeding can cause weakness, shock, and death. Anatomy and physiology of the cardiovascular system is important, so let's quickly review that. The cardiovascular system circulates blood to the cells and tissues. It delivers oxygen and nutrients, and it carries away metabolic waste products. It is responsible for supplying and maintaining adequate blood flow. That's what we call perfusion. 3 parts of the cardiovascular system include the pump, heart, container, blood vessels, fluid, blood, and body fluids. The heart needs a rich and well-distributed blood supply. It works as a 2-tiered pump. The upper chamber is the atrium, which is responsible for receiving blood, and the lower chamber or chambers are the ventricles, which are responsible for distributing blood. Blood leaves each chamber through a one-way valve. Now let's look at the blood vessels and blood. Arteries carry blood away from the heart, with the exception of the coronary arteries, which supply the heart muscle itself with blood. Arterioles, smaller vessels that connect the arteries, and capillaries. Capillaries pass among all the cells and link arterioles to venules. Venules are very small, thin-walled vessels that empty into the veins, and veins carry blood from the tissues to the heart. Oxygen and nutrients pass from the capillaries into the cells, and waste and carbon dioxide diffuse into the capillaries. Blood contains red blood cells, erythrocytes, which are responsible for the transportation of oxygen to the cells and carbon dioxide away from the cells to the lungs. Blood also contains white blood cells, leukocytes, which are responsible for fighting infections, and platelets, which is important to the process of clotting, and plasma, which is the fluid portion of the blood. Blood clot formation depends on blood stasis, which is the blood slowing down its movement, changes in blood vessel walls, and specifically we want constriction, or the body needs constriction, and the blood ability to clot. So clotting factors must be present along with platelets. When tissues are injured, platelets begin to collect at the site of injury, and the red blood cells become sticky and clump together, and the whole clotting process is initiated or begins. The autonomic nervous system monitors the body's needs, and it adjusts blood flow accordingly. Automatically redirects blood away from other organs to the core organs: heart, brain, lungs, and kidneys. The heart requires a constant supply of blood under normal body temperature. The lungs, the brain, and spinal cord, you're looking at 4 to 6 minutes. The lungs is 15 to 20 minutes without proper oxygenation. The kidneys can go up to 45 minutes, and the musculoskeletal system can go up to 2 hours. The body will always adapt to maintain a state of balance and adequate perfusion, homeostasis. Perfusion is the circulation of blood within an organ or tissue to meet the cell's needs for oxygen, nutrients, and waste removal. The speed of blood flow. It should be fast enough to maintain circulation, and it should be slow enough so that it allows the exchange of oxygen and nutrients from the cells, right? And the cells must be able to get rid of the carbon dioxide and waste. Some tissues need a constant supply of blood, while others can survive with very little. All organs. Now let's look at the pathophysiology. So really this is the pathophysiology we're looking at now of perfusion. All organs and organ systems depend on adequate perfusion to function properly. Death of an organ system can quickly lead to death of the patient. Emergency care supports adequate perfusion until the patient gets to the hospital. The heart requires a constant supply of blood. The brain and the spinal cord may last 4 to 6 minutes. The lungs can survive only for 15 to 20 minutes without good blood supply. The kidneys may survive 45 minutes. The skeletal muscles may last 2 hours. Times are based on normal body temperature. Now let's look at external bleeding. Hemorrhage means bleeding. External bleeding is visible hemorrhage. It includes nosebleeds and bleeding from open wounds. Significance of external bleeding. With serious external bleeding, it may be difficult to tell the amount of blood loss. The blood looks different on different surfaces. Estimate the amount of external blood loss, and if you see blood spurting, that can be significant. If you see the body part in a pool of blood, that can be considered significant. If the clothing look like it's soaked in blood, that should be considered to be significant. The body will not tolerate a blood loss greater than 20% of its blood volume. Changes in vital signs may occur with significant blood loss. There is going to be an increase in the heart rate, an increase in the respiratory rate, and the blood pressure will fall. Once the blood pressure falls, blood vessels constrict and the heart rate goes up. How well people compensate for blood loss is related to how rapidly they bleed. An adult can comfortably donate 1 unit, which is 500 mils of blood over 15 to 20 minutes. But if they lose this amount of blood rapidly or suddenly, they can start to show signs of hypovolemic shock. And age and pre-existing medical conditions can also affect this. Serious conditions with bleeding to look for: significant MOI. Does the patient has a poor general appearance and is calm? That's never a good thing. Signs and symptoms of shock. Significant blood loss, rapid blood loss, uncontrollable bleeding. For your arterial bleeding, and we're looking now at the characteristics of external bleeding. For arterial bleeding, pressure causes the blood to spurt and it makes bleeding difficult to control. So it mimics the contraction of the heart. It is typically brighter. It's typically a bright red color and it spurts in time with the pulse. However, if the patient's blood is depleted of oxygen, the arterial bleeding can be dark red. Venous bleeding is dark red and it flows slowly or rapidly depending on the size of the vein. It does not spurt and it is easier to manage. Capillary bleeding, this is bleeding from damaged capillary vessels. It's dark red, oozes steadily but slowly. Clotting. Bleeding tends to stop rather quickly within about 10 minutes. When skin is broken, blood flows rapidly. The cut end of the vessels begin to narrow or constrict, and this will reduce the amount of bleeding that's occurring. Then a clot forms, and bleeding will not stop if the clot does not form. So that's the body's process of dealing with that or forming clots. Despite the efficiency of the system, it may fail in certain situations. So if there's movement in the area, that can interfere with the clotting. If there's disease, patient on specific medication that can affect clotting factors or platelets. Removal of bandages can remove clots. External environment, body temperature, severe injury. Hemophilia, the patient lacks blood clotting factors. Bleeding may occur spontaneously. All injuries, regardless of the mechanism, has the potential to cause serious blood loss in these patients. Patients should be transported immediately. For internal bleeding, bleeding in a cavity or space inside the body, that's internal bleeding, can be very serious because it is not easy to detect immediately. Injury or damage to internal organs commonly result in extensive internal bleeding, can cause hypovolemic shock, specifically hemorrhagic shock. Now, possible conditions that can cause internal bleeding. They can have stomach ulcers, which consider that to be like a sore on the stomach. The liver can be lacerated, which is very vascular, so it can bleed significantly. The spleen can also be damaged, and that can bleed significantly because it's also a vascular organ, very vascular. Broken bones will bleed, especially the ribs or femur, and of course your pelvic fractures. Patient can bleed their entire blood volume out from a pelvic fracture. With each fracture in the pelvis or crack in the pelvis, they can lose 500 cc's or 500 mils of blood. MOI for internal bleeding. You have high energy MOI, should increase your index of suspicion for serious unseen injuries. Internal bleeding is possible whenever the MOI suggests that severe forces affected the body, and it can be blunt force trauma or penetrating trauma. Signs of injury, we look for DCAP, BTLS, IC. So deformities, contusions, abrasions, punctures, penetration, paradoxical motion, burns, tenderness, laceration, swelling, instability, and crepitation. Internal bleeding is not always caused by trauma, so you can have medical conditions that can cause internal bleeding. Bleeding ulcers, bleeding from the colon, a ruptured ectopic pregnancy, which is a pregnancy in which the fetus develops outside of the uterus. And one of the common areas is within the fallopian tube, and it can get to the point in size where it causes it to rupture. That can lead to excessive blood loss. Aneurysm is a weak point in an artery, so it can rupture over time and cause excessive bleeding. Frequent signs include abdominal tenderness, guarding, and guarding can be the muscles themselves guarding the area or the patient guarding the area. So the muscles can go into spasm in the area to protect it, or the patient doesn't want you to touch the area. They can have rigidity. They can have pain and distension. In older patients, we will look for dizziness, history of fainting, weakness. Ulcers or other GI problems may cause vomiting of blood. Anytime a patient coughs up blood, it is coming from the lungs. If a patient vomits up blood, it is coming from the intestine. So if they cough up blood, that's coming out of the lungs. Vomit up blood, it's coming from the intestine. They can have bloody diarrhea or urine. Signs and symptoms of internal bleeding: pain, very common. Swelling in the area of bleeding, can say distension, and distension for your abdominal injury patient is a late finding. They can have dyspnea, tachycardia, hypertension, and they can have hematoma or bruising. And a hematoma is bleeding from a large blood vessel underneath the skin, and it can form anywhere on the body, but lay people know it commonly as a coco. Anytime somebody gets a coco, that's really a hematoma, but it's not specific to the forehead. A hematoma can occur anywhere on the body. Now, bleeding from any body opening, hematemesis, is someone that is vomiting up blood. Melena is blood in the stool, that's digested blood. Pain, tenderness, bruising, guarding, or swelling. Broken ribs, bruises over the lower part of the chest, or a rigid, distended abdomen. Signs of internal bleeding continued. Hypoperfusion. When they start to get to the hypoperfusion or shock state, they start to now show changes in their mental status or level of consciousness. They will complain of weakness, fainting, or dizziness while standing. Changes in skin color. You will see pale skin before you start to see cyanosis. Later signs of hypoperfusion: the pulse become rapid, tachycardia over 100, weakness, fainting, or dizziness at rest. They start to complain of thirst, nausea, and vomiting can start to occur at this point. Skin gets cold, moist, or clammy. The breathing becomes shallow or rapid. Dull eyes, slightly dilated pupils, capillary refill of more than 2 seconds in the infants and children, weak, rapid, thready pulse, decreasing blood pressure, altered level of consciousness. All right, now the patient assessment. Scene size up, scene safety. Be alert for potential hazards. At vehicle crashes, ensure the absence of leaking fuel and energize electrical lines. In violent incidents, make sure that the police are on the scene. Follow your standard precautions. For the mechanism of injury or nature of illness, determine the NOI or MOI. Consider the need for spinal immobilization or spinal motion restriction, or if you need any other resources. Consider environmental factors such as weather. Once we have completed the scene size up, which is checking for scene safety, take standard precautions for yourself, your partner, identify the mechanism of injury or nature of illness, how many patients you have, whether or not you need additional resources. Then the next phase is your primary assessment. The purpose of the primary assessment is to manage immediate and potential life threats. Do not be distracted from identifying life threats. Form a general impression of the patient and the environment. Note important indicators of the patient's condition. Be aware of obvious signs of injury. Determine gender and age. Perform a rapid exam. Look for life threats and treat them as you find them. The patient has obvious life-threatening external bleeding, address it first. Assess skin color, determine level of consciousness. After we have determined the patient's level of consciousness, the next phase is airway and breathing. Consider the need for spinal stabilization or spinal motion restriction. Ensure a patent airway. Look for adequate breathing, check for breath sounds, provide high flow oxygen or assist ventilations with a bag valve mask or non-rebreather mask, depending on your findings. And for the airway, we position, we check if it's clear, look, listen, and feel once the patient is not talking to you, and simultaneously check for a pulse. For breathing, we check rate, rhythm, quality, and depth. Insert an oropharyngeal airway if the patient is unconscious, gag reflex is absent, and there is a ventilation problem present. For circulation, assess pulse rate and quality. Determine the skin condition and color. Look at the palms. See changes in the palm, look for changes centrally. Check the temperature of the skin. Check capillary refill time, especially for your pediatric population. Control external bleeding. Treat for shock. And shock treatment is give oxygen if necessary, keep the patient warm, nothing by mouth, rapid transport. And if protocol allows, IV access fluid resuscitation. Transport decision. After we have completed the ABCs, at this point, you should know what your patient's GCS is. You should know if it's a load and go patient, and you should know if you need to do a rapid scan or a focus. Assessment of ABCs and life threats will determine transport priority. Signs that imply rapid transport, tachycardia or tachypnea, low blood pressure, weak pulse, clammy skin. After we have completed the primary assessment, the next phase is history taking. Investigate the chief complaint, look for signs and symptoms of other injuries due to the MOI and or NOI. Note obvious signs of internal bleeding and assess the entire patient. We can get information directly from the patient, we can get it from bystanders, we can get it from family members, can look at the scene for clues, can get any information, pulse ox, pupil reaction, and GMR must be included in vital signs. Sample history, ask the patient about blood thinning medications. If the patient is unresponsive, obtain history from medical alert tags or bystanders. Look for signs and symptoms of shock, determine the amount of blood loss. Once we have completed the history taking phase, the next phase is secondary assessment. And if you complete your ABCs, patient talking to you, talk to the patient. So it's ABCs history. They're not talking to you, it's ABCs, vital signs, look at the patient, look at the scene. Secondary assessment, record vital signs, and this will include checks that you have already done in your primary assessment. So you want a full set of vitals. Consider the patient's level of consciousness, check pupil reaction, respiration with pulse oximetry, and end-tidal CO2 if available. Check pulse, check the pulse, rate, rhythm, strength. Check the blood pressure, check the GMR. So we want a full set of vitals. Complete a focus assessment of pain, attach appropriate monitoring devices if you didn't already do that before. With a critically injured patient or a short transport time, there may not be time to conduct a secondary assessment. Your secondary assessment can be a detailed systematic head to toe, or it can be a focused physical exam. It is necessary to pick up things that may have been overlooked if we were focused on the primary, or things that develop slowly. Assess all anatomic regions for DCAP BTLS IC. Look for uncontrolled bleeding from large scalp lacerations. Feel all 4 quadrants of the abdomen for tenderness or rigidity. Record pulse, motor, and sensory function in the extremity if there is extremity trauma or you suspect spinal injuries or some type of neurological issue. Vital signs. Assess vital signs to observe the changes that may occur during treatment. A systolic blood pressure of less than 100 millimeters of mercury with a weak rapid pulse should suggest the presence of hypoperfusion. And once you get that blood pressure reading, find out what is the pulse pressure. Cool, moist skin, that is pale or gray, is an important sign. Once we have completed the secondary, the final phase of the assessment is the reassessment. Repeat the primary assessment in areas that showed abnormal findings. So when you're repeating your primary assessment, pay attention to areas that you had issues with. Signs and symptoms of internal bleeding are often slow to present. Reassess an unstable patient every 5 minutes and a stable patient every 15 minutes. So we will contact the receiving facility to radio in our report, and it will involve what the patient tell us, what we observed, what we did based on observation, how the patient responded, method of transportation. And when we document, we are going to use SOAP, chart, or chronological order. Interventions. Pay attention to your interventions. Are they working? Is the patient getting better or worse? Do you need to make adjustments? Do you need to rendezvous with ALS, or you need to find out how far ALS is? Provide high flow oxygen, control external bleeding, provide treatment for shock and transport. Do not delay transport of a patient to complete an assessment. Communication and documentation. Recognize, estimate, and report the amount of blood loss and how rapidly or over what period of time it occurred. Communicate all relevant information to the staff at the receiving hospital. Document all injuries, the care provided, and the patient's response. Emergency medical care for external bleeding. Follow standard precautions. Wear gloves, eye protection, and possibly a mask or gown. Might not have the opportunity to put on a gown in all situations. Make sure the patient has an open airway and is breathing adequately. Provide high flow oxygen if it is necessary via supplemental or positive pressure ventilation. Control obvious life-threatening bleeding as quickly as possible. Several methods are available to control external bleeding. We have direct, even pressure, and elevation. Pressure dressings or splints and tourniquets. Commercial tourniquets or improvised. For direct pressure, the most effective way to control external bleeding is to apply direct pressure. Pressure stops the flow of blood and permits normal coagulation to occur. Apply pressure with your gloved finger or hand over the top of a sterile dressing. Sometimes you may have to put your gloved hand directly on the wound while your partner get the dressing. This pressure must be uninterrupted for at least 5 minutes. Pressure dressing. Firmly wrap a sterile, self-adhering roller bandage around the entire wound. So dressings go on the wound, directly on the wound. Bandages hold the dressings in place. I have various types of dressing. I have various types of bandages. Use your 4x4 sterile gauze pads for small wounds and sterile universal dressing for larger wounds. Cover the entire dressing above and below the wound. Stretch the bandage tight enough to control bleeding, but it should not be so tight that it cuts off the distal circulation, or the patient complains of numbness or tingling sensation after. Do not remove a dressing until a physician has evaluated the patient. Bleeding will almost always stop when the pressure of the dressing exceeds arterial pressure. Hemostatic agents, these are chemical compounds that slows or stop bleeding by assisting with the clot formation. It is not routinely used in EMS at the moment, but it is used in the Army. So they're starting to do research on its application to figure out which one is best suited to be used. So research is being done on that. It can be used with direct pressure when direct pressure alone is ineffective. The use of hemostatic agents in EMS remains largely experimental. Be aware of and follow local protocols. For the tourniquet, it is useful if a patient has substantial bleeding from an extremity injury. Now, a tourniquet is not a simple device or a simple procedure for controlling bleeding. And that's a very common misconception. So a lot of people just believe that all you're doing is tying up a person, leg or arm, and you have a tourniquet. It doesn't work like that. It has to be done a particular way, and the pressure must exceed pressure inside of the vessels, and the bleeding must completely stop. Therefore, if you're not trained to properly apply a tourniquet, you should not be doing it. And if it's going to be allowed in your protocol, you are required to do workshops in its application. And in the workshop, you should be utilizing commercial tourniquets and you should know how to improvise the use of tourniquets. Now, in some situation, it may be your first option. In others, it should be your last resort. So there are some situations in which you might want to put on a tourniquet right away, depending on where the injury is and where the bleeding is occurring from. And then there are others where it will be a last resort. Now, two situations, well, I can say three. If there's arterial bleeding present, if it's a large artery that's the blood flow is coming from, then you might want to consider putting on a tourniquet right away. If it is a crush injury, so if the patient has a crush injury, I would definitely put on a tourniquet on that patient's limb, especially if the area has been crushed close to 4 hours. Right, so if they have been pinned down for 4 hours, they are at risk for crush syndrome. So what is going to happen is all of the tissue that has been crushed during that time frame is now dead tissue and it becomes toxic. So if the pressure is released off the crush area, all of that is going to circulate into the blood, and it can cause significant problems with the patient's kidneys, and it can cause significant issues with the patient's heart. So that's crush syndrome. So a patient with a crushing mechanism, I would consider putting on a tourniquet, especially if I'm going to release that crush mechanism. The other situation in which I would definitely put on a tourniquet is if the patient has an amputation. Now, it wouldn't be my immediate go-to because I would try to pack that wound first, and then if that doesn't work, I would consider using a tourniquet in combination. If a commercial tourniquet is available, you can create a tourniquet. Sorry, if a commercial tourniquet is unavailable, you can create a tourniquet using a triangular bandage and a stick or rod, but it must be done in a particular way. Also, which is not in your curriculum currently, there are situations where we may have to pack the wound. So you may have to do something called wound packing, right? So these are for patients where a chunk of the tissue is gone. So it's a deep cut. And I'm talking about areas like the armpit, the groin, or lacerations that go very deep and create a gap in the skin. You can't just put a dressing over that. You're gonna have to pack that space, and the gauze that you're applying must be creating pressure on the blood vessel that is bleeding. So you may be required to do wound packing. So you have to pack it and then you bandage it. Observe the following precautions for tourniquet. Do not apply a tourniquet directly over a joint. You can cause permanent damage to the patient's joint. Always place the tourniquet proximal to the injury. That means the tourniquet should be closer to the body than the injury. Make sure the tourniquet is tightened securely. So once you tighten it, it has to stay, that pressure that has been built up must remain. Cannot lose up that pressure, certainly not in the field. Never use a wire, rope, or a belt, or any material that can cut into the skin. Observe the following precautions. place padding under the tourniquet. Never cover a tourniquet with a bandage. So anywhere you apply a tourniquet on the body, it should not be covered, and you need to ensure that you record the time that it occurred. And we use the symbol TK for tourniquet and time. So the time that it was applied in the field must be noted, must have that information for the receiving facility. Do not loosen the tourniquet after you have applied it. All right, now splints, ear splints specifically. Soft splints or pressure splints can control internal or external bleeding associated with severe injuries. Immobilize fractures. So a splint can immobilize fractures. If the fracture is immobilized, that will stop the bleeding from the fracture. It can act like a pressure dressing. It use only approved clean and disposable valve stems. Not gonna see a lot of ear splints in Jamaica. Rigid splints will help immobilize fractures, reduce pain, prevent further damage to soft tissue injuries. Once a splint is applied, monitor circulation in the distal extremity. You will definitely see a lot of rigid splints in Jamaica. Bleeding from the nose, ears, and mouth. Several conditions can cause this. Skull fractures, facial injuries, sinusitis infection, use and abuse of nose drops, dried or cracked nasal mucosa, patient with high blood pressure. High blood pressure is a very common cause of nosebleeds, coagulation disorders, digital trauma. So epistaxis, nosebleed, is a common emergency. Occasionally, it can cause enough blood loss to send a patient in shock. That's not something you will see commonly occur. Can usually be controlled by pinching the nostril together and have the patient lean forward. So don't have them lean the head back. If they're leaning their head back, the blood is going to end up in the patient's ear passage. If that doesn't work, you can so when they pinch the nose and lean forward, if that's not stopping the nosebleed, you can wrap a ice pack in paper towel and put it on the forehead to constrict the blood vessels. Bleeding from the nose or ears following head injury may indicate a skull fracture. It may be difficult to control. Do not attempt to stop blood flow. So if you suspect a skull fracture, do not try to stop that bleeding. Loosely cover the bleeding site with a sterile gauze pad. And really what we're doing with that gauze pad, we're trying to catch whatever fluid is coming out and examine it. Apply light compression with a dressing. If you see a target or a halo-shaped stain, then that's not just blood alone. That's blood and cerebrospinal fluid. Emergency medical care for internal bleeding. Usually requires surgery or other hospital procedures. Keep the patient calm, reassured, and as still and quiet as possible. Provide high flow oxygen, maintain body temperature, splint the injured extremity with the ear splint. Can use rigid as well. That would be the end of this particular chapter. So bleeding is a pretty straightforward chapter. Question 1. Which of the following is not a component of the cardiovascular system? Let me stop the recording.